random chance. So it's almost a random event in the sense that we advise people to have sex 2 to 3 times a week, and then they will get pregnant somewhere along the line. Nowadays, there are tests to test for ovulation. People can time intercourse. So I guess with time, it's not impossible that the concept of waiting for 12 months to define infertility may change. But again, this is open to discussion in this forum. What are the things needed to achieve pregnancy? Well, a lot of them, we need the organs, we need the testes, we need the ovary. I think, as in this picture, so there is need for the uterine cavity, there is the ovary, then there's the tube that carries the eggs and the sperm back into the uterine cavity after fertilization. Of course, you can go through the vagina, the cervix, and then for men, you have the testes, the epididymis, where the sperms are stored, and also the tubes that goes from that to seminal, where the seminal vesicles, and as well as the urethra, where the sperms come out from, and then the prostate along the line to for nutrition purposes. So those are the organs that are necessarily needed, and any disease along any of these organs could affect fertility possibility. So when you look at the causes of infertility, we're looking at about 39% of it, 33% will be female and 20% is male. Actually, 39% is combined. And then we have a little proportion of 8% that everything is normal, but yet no pregnancy. So those are difficult to manage. And oftentimes, again, after a bit of trial, people just get pregnant spontaneously. As I am a gynecologist, I won't be able to talk a lot about male infertility, but maybe for future, for the network, we might get a urologist or andrologist to talk about male infertility aspect. What are the things that could happen in females? You could have the tubes blocked, the ovaries may not be releasing eggs, the uterus itself, cavity of the uterus may have abnormality, which could preclude possibility of embryo implantation. And then there could be a lot of adhesions, which makes the ovary not accessible to the tubes. These are the common things. Of course, infection is a common cause of tubal damage due to adhesions, related to adhesions and everything that can happen around the cervix, and the infection often comes through the cervix. So that's why it's there. I'll just take things one by one as we go along. Now, fertility treatment is become revolutionized. I think if there's anything that has changed, is actually the fact that the surgery that we used to work on for a long time when I was much younger actually has become almost not obsolete, but we are finding a new role for it. Assisted conception techniques, which has started since 1978 with birth of Louis Brown, has changed the way we think. However, it's very expensive, psychologically quite exhausting, and often the last bastion of hope for most people sometimes. So efforts has been continuously worked on in the last years to actually improve the outcome of assisted conception. And it's in two fronts. That's in quality of eggs, the embryo development, quality of the endometrial lining, which one of my colleagues will talk to you about all the different tests that one does for fertility. And of course, the improvement in the pelvic environment, which is where people like us come in, which as a surgeon. The surgery itself, it includes fertility outcomes. The basic thing about surgery is to return abnormal to normal, and then you improve the physiological functions of the organs. So that's what surgery is all about, and that's what we try to do. The success of assisted conception is, however, is also related to having a normal or near normal anatomical integrity of the pelvic organs, and then the physiological functions of the reproductive organs. So when you join the two together, you actually get a better outcome with assisted conception treatment. So oftentimes, we are now becoming more of a complementary surgery to make assisted conception better. Of course, primarily also in some people, they may not even need assisted conception just by virtue of doing the surgery. But I will explain myself in a little bit later. What are the different surgical approaches? Well, it could be diagnostic in the sense that you're actually using it to investigate why a woman is not fertile or is not able to achieve pregnancy. The commonest tool we use there is hysteroscopy, in which case we will explain that in a detail in a short moment, and also laparoscopy. Both are keyhole surgery to assess the pelvic environment. Of course, it could be therapeutic in the sense that we use the same kits to actually remove things that could contribute to infertility, like polyps, adhesions, septum, and in recurrent failed IVF, and also fibroid. Of course, we do laparoscopy to facilitate treatment of endometriosis, release of pelvic adhesions, removal of fibroids, and tubal surgery. Finally, we do laparotomy. That is when we open the abdomen to remove things like fibroids and cysts. So all these are complementary to surgery. Those are the surgical treatments that could affect fertility treatment outcome. So let's start with the basic one. Hysteroscopy. Hysteroscopy is essentially putting in a tube through the neck of the womb, which is we call cervix, to look like at a camera that will give you an inside view of the lining of the womb. The way I discuss with my patient it's quite easy when it comes to hysteroscopy in fertility care. We all love a very lovely bed to sleep on. So the way you will lay your bed smooth and put all the necessary things there, and then you can sleep comfortably at night. But can you imagine if you lay your bed and you put your computer on it, your phones on it, and also some other books you are reading? Invariably, you bounce into it, to all those things on the bed in the middle of night, and that might just wake you up. And children are like that, technically speaking. So what is important is the lining of the womb to be safe and be a comfortable place for a baby to actually sleep in during the course of the 9 months. What are the things we can use it to treat? Often it's a day procedure or office procedure. Office procedure because we miniaturize the tools we use for it now in such a way that you can easily just do it even without anesthesia. Of course, if you're just checking the cavity, that's much easier. If you're going to be doing some therapeutic things there, like removing polyps, removing fibroids, and then it may be best done under general anesthesia, which takes about 5 to 10 to 15, 20 minutes, depending on what you have to do there. The tools we use in addition could be scissors, especially if we are releasing scar tissue. We can use scissors to remove polyp as well. And then we use new power musculators now that can easily be done without anesthesia as well, like TrueCut or MyoSure. This can be done as an office procedure as well. And then the more advanced way of doing it again is using the resectoscope. The resectoscope is a loop of electricity, which could be either bipolar or monopolar. The difference in that is just the energy mode. The bipolar is a little bit safer, is a bit better in the sense that it doesn't destroy outside the area you want to treat. So there's no residual heat in it, but it's still equally good to use monopolar. The recovery is quite quick. As I said, most people will have it done as a day case, and they can go home on the same day. What are the things we can see? If you look at these pictures, there are different things. Intrauterine adhesions, such as septum, these are congenital things. Sometimes this is also acquired, either from surgery. The commonest surgery that leads to adhesions is actually open mammectomy. When you do fibroid and you open into the cavity of the womb and you remove fibroid from the lining of the womb, then they could cause a bit of scar tissue. Of course, if the surgery is done by not people who are well trained, then it might cause that. Often that will come through with the patient also not having either a period or the period suddenly become much lighter and spotty. Additions could also be from intrauterine treatment like a D&C. If you have a lot of population from developing countries where people have had, because termination of pregnancy is not legal. So people have gone to backstreet abortionists and they may have caused some damage to the lining of their womb. But more commonly in the UK, you'll find fibroid, which is this mucosa fibroid. These are just fibroid tissues that are in the lining of the womb. And then the last but not the least, depending on the age of the woman, sometimes polyps are pretty common in the older age group that are having fertility treatment. So very rarely, it's worthwhile to check the cavity of the womb, before fertility treatment, especially if you've done a scan that is suggesting that any of these things could be happening, or the history taken is suggestive of the fact that there could be some irregular periods or intermenstrual bleeding or heavy period. These are the ways they manifest, and then hysteroscopy will pick it up, and you can do it as a see and treat. What are the outcomes? Removal of endometrial polyps has been shown to actually improve pregnancy outcome by almost double the rate. Similarly with submucosal fibroid, but more important with submucosal fibroid, so it reduces the rate of miscarriage by over 10%. The intrauterine septum depends on which paper you are quoting. Some will say there's no change, some will say there is change. But again, it's worthwhile to make the endometrial cavity regular before you do the treatment for IVF. Intrauterine adhesions, as I said, is not common in this environment, luckily, but it is common in developing countries. And then also it's a little bit much more difficult to treat. And this, you may need to defer transferring the embryo until the endometrial lining is reasonably restored back to normal. In women who have had failed assisted conception, sometimes it's advised they just check the endometrial lining with hysteroscope. And the outcome of that has shown that actually most women who have tried before and they were not successful, when you do hysteroscopy and you do endometrial scratching, they actually have increased chance of carrying pregnancy to term. Okay. The next aspect of our work is around laparoscopic surgery. It's a little bit more invasive. It requires a bit more expertise and also carries slightly more risk. Often done under general anesthesia, and it's often as a day case in most states. In most of course, there could be need for admission overnight if there had been complications. And what are the areas of its use? Tubal surgery, which is, I'll explain that in a minute, ovarian disease, endometriosis, and uterine fibroid. So these are the common areas where laparoscopic surgery comes into play in improving fertility treatment outcome. The first one is endometriosis. Most of us may be familiar with all these gory pictures online. You can see them. These are endometriosis. Essentially is when the lining of the womb is outside the lining of the womb. So the similar cells as to the regards to the one that is in the lining of the womb. So invariably what happens is that there is regular menstruation from those spots of areas of where the lining of the wombs are. So it causes a lot of pain, a lot of with period, as well as also a lot of heavy period as well. So all these areas with abnormal looking cells are where endometriosis are. But because the body doesn't like blood in its space, so whenever the blood spills into the cavity, the body tries to repair it, and then it forms a bit of scar tissue, and which can become progressively worse as endometriosis remain untreated. These are severe endometriosis, in which case is actually going into the back of the rectum, and a lot of people with this kind of endometriosis may also suffer pain during sex, and that also reduces the chance of getting pregnant. Endometrial chocolate cyst is quite common when the endometriosis is in the ovarian tissue, and then it's walled itself off, and it becomes progressively getting bigger. Then it may compromise the ovarian reserve in the patient in terms of spreading it out. So those are the things one could find in endometriosis. Okay. The surprising thing about endometriosis is that there's no direct correlation between how bad endometriosis is and fertility potentials. But if a woman has been trying for pregnancy, or she's tried IVF and it's not successful, treating and checking, doing a laparoscopy, and you find endometriosis has been shown to improve the outcome of the treatment, especially in the mild endometriosis. Then if there are endometriomas, that is when the cyst is in the ovary, then if it's more than 3 centimeters, it's worthwhile to go and remove it or to go and treat it. What you do, Now depends, people will say if the woman is a little bit older, it's most important that you just remove it. I mean, you just drain the cyst and then bond the base of the thing so as to reduce the risk of ovarian reserve that with the patient. But more important, most people will try to actually do to remove the cyst. I think it's still a best way forward, because if you just drain it, it might come back. Okay. Tubal surgery, these are consequences of infection that has damaged the tube, especially at the distal end. Then what you then have is this saxophone-looking tube when you do an HSG, which is a way of investigating for tubal disease. Or if you are good at scanning, you might be able to pick it up at scan as well. And when you do a laparoscopy, this is what you get, a saxophone-like ballooning of the end of the tube, because the tube is like a fingers at the end, but when that finger closes, then it forms a pouch, and then the secretions of the lining of the tube, as well as the retrograde flow of blood during menstruation, is what usually would lead to these hydrosalpinx. And of course, the flow can be both ways. So if you put the embryo back and then the flow goes back, it might create a kind of a toxic environment for the developing embryo. So general opinion is that you should treat hydrosalpinx. And how do we treat it? We can treat it laparoscopically by excising the tube that is damaged, which is always a very difficult discussion, because for somebody who's trying for a baby, even though the tube is damaged, even trying to still remove the tube can be a problem in terms of accepting the fact that that road is closed. We don't tend to do tubal surgery anymore, in which case we used to make a hole in the tube, drain it, because it's been shown that it reaccumulates back rather quickly. The other thing, access may be poor, in which case you can't actually remove the tube safely. Then it's sometimes in such situation, putting a clip close to the distal end of the proximal end of the tube will reduce the risk of it contaminating the environment. Also, you can do it from inside the uterine cavity, sometimes through hysteroscopy, but it's not popular now after the problem that was being found to be associated with issue some years back. If patient is not amenable to surgery, as it could happen sometimes because of all that morbidity, then ultrasound drainage of the hydrosalpinx could be attempted. But it's not, because again, it forms back rather quickly. Maybe it's not the best way forward for a management of hydrosalpinx. So what are the outcome of it? Surgical outcome of remove or damaged tube, it improves the pregnancy success rate after IVF by about 1.9%. As I said before, surgical occlusion is another option. The drainage of the tube, I've mentioned that. There has been suggestion that you could have a lower ovarian reserve from the tube that you have, from the side where you have removed the tube, but it doesn't seem to affect the response to ovulation induction. Most people will not remove both tubes at the same time because of this little risk of reduction in ovarian reserve. There are schools of thought of recent now that says that, look, we don't need to actually remove the tube, even in hydrosalpinx, because they are transferring at a blastocyst stage, which is a little bit better in terms of being able to withstand a no-style environment. But again, in fertility, it's always a little bit, if you're spending quite a lot of money, you want to optimize the chance of success. So, a lot of people are saying that maybe over time, the idea of removing the tube may become not so much important. Next thing is the ovarian disease. In this country, I think an ovulation is a common cause of subfertility because of polycystic ovarian syndrome. Most people will actually get pregnant if the other parameters are met in terms of normal tubes, normal sperm, and the normal endometrial cavity. by using ovulation induction, in which case you do your HSG, you find that the tubes are patent, the man has done his sperm test, and it's actually fine. So in which case you can give clomiphene, and that with ovulation stimulation and timed intercourse, people could get pregnant. If clomiphene is not working, then you can try gonadotrophin stimulation. However, there are people who are resistant to both clomiphene and gonadotrophin, and then there is a treatment you can do, which is laparoscopic ovarian drilling. Essentially, you make holes in the ovary. Usually, we take one ovary at a time, and then you make about 6 to 12 holes, depending on the school of thought you belong to. Again, it does. Some people will have spontaneous ovulation after this. Some we still need ovulation induction with clomiphene or gonadotrophin. The good aspect of ovarian drilling is the fact that it reduces the multiple pregnancy rate, especially if you're trying to achieve pregnancy without assisted conception. There's no advantage in unilateral or bilateral ovarian drilling, so most people will just do one at a time. Okay, fine. Then the last of the big event in fertility surgery is the issue of fibroids. Fibroid is quite common in a lot of races. About 70% in Black women, actually, we have fibroid. But having a fibroid often is not so much of an issue when it comes to fertility, unless the location. Now, we are very interested in the location of fibroid when it comes to subfertility, because we're looking at the location, whether it's in the lining of the womb, whether it's in the muscle of the womb, whether it's the skin of the womb, or whether it's just pedunculated. There is a classification system we all use, which is the FIGO classification. The FIGO classification is from 0 to 7. So this is to guide what is happening, because if all your fibroids are 6 and 7, it doesn't necessarily matter apart from pressure symptoms. It probably will not affect the cause of the outcome of the pregnancy. Again, the way I explain that is very simple. You have a lovely bed, it has a drawer, and you put all sorts of things in the drawer. As long as what you put in the drawer is not bad enough to push on your mattress, it should be okay. So, but of course, it may make the pregnancy a bit turbulent in terms of pain, because fibroids do grow in pregnancy, they outgrow their blood supply, and then they cause a lot of pain. So you could remove it for the sake of that. Of course, it may affect the way a woman delivers. However, if the fibroid is in the lining of the womb or close to the lining of the womb, but in the muscle, and also in the muscle, like the type 3, type 4, then, and it's more than 5 centimeters, those fibroids are associated with a slight increase of miscarriage. So removing them may be worthwhile. Anything less than 5 centimeters, actually, there's no change in outcome in removing it. And you may be causing more harm than good, especially if it's going to be done in an open surgery. The main way fibroid affects fertility is essentially to do with the affecting the sperm migration, ovum transport, and embryo implantation, which means that the area is not comfortable for baby. After fibroid surgery, most of us will use anti-adhesion agents to reduce the risk of adhesions forming. That's scar tissue, because fibroid tend to excite the tissues. The tubes could become blocked, and that's why, especially when you are removing multiple small fibroids, those ones could actually lead to tuber damage. Various ways of doing it, depending on this location and the expertise and the size and how many they are. Hysteroscopy is a way if it is in the lining of the womb, a laparoscopy if it is in the muscle of the womb, and open surgery if it's very big fibroids, and there are many of them, in which case it's a shorter operation to do open surgery then. And of course, in fibroid surgery, you tend to have a tactile way of feeling for it. It's difficult to do that laparoscopically. So you may remove one big one laparoscopically, but you may still leave some, especially if you have been given Zoladex or any of the injections before the surgery. Then invariably, those ones will grow back a lot quicker once the effect of the Zoladex wears off. So one would have missed them at the time of the surgery. So open surgery sometimes, to me, still seems to be a better way in fibroid surgery. I'm coming to an end. So just to wrap up, reproductive surgery is evolving in a different way to complement fertility care. Assisted conception has announced the success of fertility treatment. We thank God for that. But again, to make that worthwhile, we go back to normal functional anatomy and physiology. And the role of surgery is to return to normal functional anatomy and physiology of the reproductive organs. Most procedures are actually done as a keyhole procedures, in which case, most of them are day cases. So it reduces morbidity and also length of stay, and the side effect is much less. However, we still have a role for open surgery in some of the more difficult cases. And thank you.
Thank you so much for that comprehensive presentation, Mr. Fakokunde, and sharing your expertise. We have got some questions come up, so just conscious of time, so wanting to actually just move on to the questions, some of which you already may have answered, but I do want to move on to that. So thank you very much. So I have a question here. If you are in your 40s and know that you have blocked fallopian tubes and small fibroids in the wall, so I assume that means the wall of your uterus.
Yeah.
It's changed the shape of the uterus, and that's been identified through a HSG. Is it recommended for you to have surgery prior to starting IVF in order for egg collection to be more successful?
Yes, that's a very, when the uterus grows with fibroids, it can sometimes move the ovaries away from being a pelvic organ to an abdominal organ. And so invariably access is poor to get the eggs collected, naturally from the transvaginal route. And then you may want to do a transabdominal route. The other thing is that too many things look alike, even though ultrasound is a bit better, is quite modernized now. And then you can see the eggs, developing eggs. So in situation as such, that it will be worthwhile to remove those fibroids for access, mainly for access, and also to improve the outcome of the pregnancy.
Thank you so much.
Of the treatment, yeah.
Yes. And so on to the next question. We have an attendee who says, I have Asherman syndrome. Had my third operation on Friday to remove adhesions ahead of my frozen embryo transfer. Is there anything I can do to prevent it coming back? Her consultant has put her on 2 milligrams of estradiol and inserted a copper coil, she thinks.
Yes, right.
Is there anything else that can help with for the adhesions not to come back?
That's actually a very difficult situation to get to treat. Open mammectomy, usually it's the commonest cause in this environment. And it's often, as you rightly said, when you've entered into the cavity during the course of the surgery. Now, to manage it, you can either manage it fresh at the time of the surgery, in which some people will put a balloon catheter for about 3 days inside the cavity so as to separate them. Once scar tissue are formed, it becomes more complex to repair and to grow. Normally, I always advise, if you have to go for the third attempt, the question I haven't, because I'm looking at the question, is that did she menstruate with the first and second attempt? Because that's what is important. Because if there are residual endometrial lining, cavity is like a grassland. So if you have patches of area, but as long as there are grasses around, they tend to migrate to it to cover the area of scarring. So what the copper coil is doing is to separate where they've just opened up, and the estrogen she's been given is to, like a fertilizer, to the area of endometrial lining that is available. There's nothing much you can do more than that in terms of doing it. But as I said, the most important question is, did she menstruate with the first and second attempt at correcting the scarring? If she did menstruate, then there is good hope that things will get better. If, however, she did not, then that's a little bit difficult to predict the outcome.
Okay, thank you for that. I see that the attendee has said that she did menstruate and that the lining at the top of her uterus is quite good.
Good. That's a very good. Then things will be, she's doing the right thing. I think she should be positive. The outcome is most likely to be positive in that situation. Okay.
Right. Thank you for that. And the next question we have is there any surgery which can improve damage from adenomyosis?
Adenomyosis is it's not surgically treatable, apart from when it forms what we call adenomyoma. There is a situation where adenomyosis is just like you have a tissue that you have sandwich of endometrial cells inside of it. So the best way to manage it is to give a GnRH analog, because the principle of endometriosis and adenomyosis treatment is very simple. The endometrial lining in the lining of the womb has what we call basal cells. This basal cells is what regrows every month. Okay? However, when the lining of the womb is outside the pelvic environment or in the muscle of the womb, they don't have the basal cells. So the best way to manage it is to kill the cells altogether by giving Zoladex or Proza, the other one, let me say, I forgot the trade name. Prostap. You want to give Prostap or Zoladex. So you can give it for up to 3 to 6 months, and the expectation is that you destroy the endometrial lining outside the lining of the womb, because they can't regrow. There's nothing to feed them. So when you stop the medication, then the chances that things will get better. The endometriosis, the adenomyosis and endometriosis will be much, much better. And it's, of course, new island of cells may grow, but it will take a bit of time. However, if you have a coalition of adenomyosis tissue in a particular segment of the uterus, you can go and excise it. Now, the problem with adenomyosis is that it's very difficult to repair. If you cut it, what you get is like a cheese wire when you're putting sutures. So what we've used in the current time is to do a barbed suture, but it causes a lot of bleeding as well. And more important, if you cut, because you don't know where to stop when you are cutting to excise adenomyoma, you might cut into the lining of the womb and then result in Asherman syndrome as the in front. So as the first question is, so generally speaking, most of us will defer going for adenomyotic surgery to remove, unless there is what we call adenomyoma, in which case you can locate it. If you've seen fibroid removed, fibroid is like a wall. It's like peeling off a walnut. So it's very easy to remove fibroid. But adenomyosis tends to be more diffuse and all over the lining of the muscle of the womb. And so it's difficult to cut out. So surgery is not a primary way to treat it.
Sure. Thank you for that. And you've also mentioned about some of the medical management with the medications that you mentioned. What about Ryquo? Can you say a bit about Ryquo in the treatment?
Right. Yeah. Well, why I didn't mention Ryquo is Ryquo is useful in reducing period, because Ryquo is actually like it's like Zoladex and what do you call it, and Prostap in terms of managing fibroid bleeding. Again, essentially, what Ryquo is that Ryquo is a combination therapy of HRT with with something to stop the ovary working. So you don't get the side effects. Anybody who's taken Zoladex before, we know what Zoladex does. It kind of pushes people into acute menopause. That's essentially the way it works, because it stops the ovary working. But what Ryquo has is that it has estrogen and progesterone combination in the tablet, which now reduces the side effect from that. The trial on its use in adenomyosis will come out in the next 2 to 3 months, in which case it will be licensed to be used formally for that. We've always used it now in combination for women with adenomyosis and fibroid, and that works well. Whether it will be useful in endometriosis, I think future will decide that. But I think adenomyosis is coming up. I was speaking to the drug rep just about a month ago, and then at a presentation in Chelsea, and then this issue was raised again. But it's coming up. It may be a kind of game changer with time.
Thank you so much for that. Our second to last question is, if you have endometriosis and two 2 millimeter cysts in each ovary, would you recommend surgery before IVF versus the risk of damage to the ovary or loss of eggs?
You're very right on that. As I said, see, I was at a conference about 2 years ago in Derby on this issue of endometriosis and fertility. Generally speaking, unless you've had failed treatment, most people will not treat endometriosis primarily. Don't forget, endometriosis, of course, causes more to do with menstrual problem in terms of painful, heavy period. If that is the main issue why the woman is having endometriosis treatment, then that's worthwhile. If, however, the treatment is as a result of fertility, I wouldn't prioritize the endometriosis treatment until after the egg collection and everything. That may just be worthwhile. I would do it as a primary procedure.
Thank you. And so our last question for tonight, before we end, is one of the attendees has asked, I have Asherman's, had a myomectomy to remove fibroids. Why does the scarring occur?
As I said before, Asherman's syndrome is intrauterine adhesions. Myomectomy is depending on the location of the fibroids. If the fibroids are located close to the lining of the womb, or she's got multiple submucosal fibroids, then the chance is that when you cut out those fibroids, the areas that are left in the areas of removal of the fibroid will form a little bit pocket of scarring. The more you remove the submucosal fibroids, or alternatively, when you try to remove the muscular fiber, the one in the muscle of the uterus that is close to the lining of the womb, if you breach that cavity, then the Asherman's could occur. If most times when you suspect that can happen at the time of your surgery, what people do will be like 6 weeks back, bring you back to do hysteroscopy and then break the adhesions before they become mature. And then you put a coil inside and give estrogen with progesterone. And the other times, so as a preventive measure sometimes, if you've opened the cavity back and front or side to side, what you could do is you can put a intrauterine balloon catheter at the time of the operation. If you remove it in about 3 or 4 days, or some people will keep it up to 10 days, and then you remove it, after that, it keeps the cavity separated so they don't merge with each other. And endometrial lining tends to migrate to themselves. That's a problem. So when they do that, then they can form a bit of they close the spaces in the intrauterine cavity. And that's why people have Asherman's. Asherman's is when it's quite severe. Majority are actually quite mild. And you can break it down within 6 to 8 weeks of the surgery to just make sure. So check hysteroscopy. But the problem sometimes is nothing is, unless you are doing it in NHS, so nothing is ever free. So if you're doing it privately, it costs about, I don't know, 8 to 10,000 to do this fibroid operation. And somebody says 6 to 8 weeks time, cough out another 3,000 pounds to look into the cavity. It all adds up. So people tend to just think that if your period is regular and it's coming better, then, but if your period becomes suddenly not coming as much as it should do in terms of the volume and flow, and it's quite light, then it's worthwhile to just check the cavity before it eventually matures and close the cavity.
Okay. And just because we got started a bit later, I'm going to sneak in one
final. Don't worry, I'm free. Don't worry. I'm sorry about it later. You can ask as many questions as you want. I'm not running away. I'm okay. Don't worry. I took 20 minutes to get my IT sorted, so I'm happy to discuss more. Yes. The lecture is just as a guide. Yes. The discussion is more important.
Perfect. Okay. So we have another question, which is the attendee says, I've had I can't pronounce
adhesiolysis, yes.
Thank you.
Okay.
Done. Which is what is the optimum interval to do an embryo transfer to prevent a reoccurrence?
Adhesiolysis of where? Is it of the uterine cavity or of the pelvis? I think it needs to be a bit more specific.
Okay.
Because if it is hydrolysis of the pelvic environment, which is almost unnecessary if you're doing assisted conception, I suspect it's going to be hydrolysis of the uterine cavity. Okay, so that's that now. Yes, if in that situation, usually they will give estrogen with progesterone, and then they will say either 1 or 2 months, depending on the severity. If it's a light one, I usually just write for assisted conception after the next cycle. If it's a mild adicylysis, if it's a moderate one, I want to actually encourage the lining of the womb to grow and become a bit more luxurious in terms of, the surface area. So I will give estrogen with progesterone for about 1 to 2 months, and then you do embryo transfer after that.
Thank you so much. I just asked if there's any burning questions from any of our attendees, and to see, otherwise we will wrap up. The person who did ask the previous question said it was the uterine cavity.
Yes, I guess as much. Yes, that will be the one, and that's it. It's actually it's surprising that we have a lot of uterine related questions, because it's not so much common here compared to what I get if I go and do some charity hysteroscopy work in Africa, because that's where the real issue is with endometrial adhesions.
And there's a question that's come through in terms of, with some of the uterine issues, when might you recommend for a patient to consider surrogacy?
Yeah, okay. It's one of, like the first question we were talking about, intrauterine adhesions that has been done 3 times. I mean, if the 3rd time doesn't work, I will probably suggest that surrogacy will be an answer. Again, if fibroids, if you've done fibroid surgery 2 or 3 times, then the 3rd time is usually a lot of difficulties, because at the end of the day, you want to be alive to look after the baby. You want to be in great health, because delivery can be quite difficult as well if you've had a lot of intra-abdominal adhesions. So if in such situation, I always suggest that, okay, maybe you've done your bits, then you can, if you still have good embryo, let somebody do the job, because it's almost the same outcome in terms of feeling. Of course, the feeling of getting pregnant is not there, but at least you got a child, and it's also alive to look after such child. So that's my own thinking. That's my own thought process when it comes to when do you call it a day. Intrauterine adhesions is the most difficult one. Then multiple fibroid surgery is the next most difficult one.
And would you also say adenomyosis can also be a reason?
Adenomyosis, yes, if it's adenomyosis can be a bother, but if you do the hysteroscopy, I didn't show you the slides on what adenomyosis, I look at hysteroscopy. If the adenomyosis in such a way that it's kind of distort and damage the lining of the womb, then it may be worthwhile to consider it after difficult adenomyosis as well.
Okay. Thank you so much. We've not had any further questions come through, so just the last check.
Okay.
So I think, I spoke too soon.
Okay.
There is one here, which is asking, is it correct that for severe adhesions removal, it is best to ask the surgeon to use micro scissors rather than using heat or myosaw?
Very, very true. Scissors is always the best tool for adhesions, because, when I was talking about resection of fibroid as well, I did mention that the bipolar energy and monopolar energy. Monopolar energy, the energy spreads. Bipolar, the energy is contained to the area you are managing. Then in adhesions, what you are trying to do is to actually release the scar without damaging more cells. So if you use the electrical energy, you are damaging the cells, and they don't tend to recover quickly. However, if you can use, most people will use scissors. I know there are quite a few people who try to use the, what do you call it, the electric pull. It's a bit more, the risk is actually a little bit more because you may not be able to control it, and you can, and seriously, you can easily perforate the uterus in intrauterine adhesions. So generally speaking, most reproductive surgeons will use the scissors, and I think it's a preferred option. It reduces the risk of damage to the lining of the womb.
Sure. And is embolization something that can be harmful to going on to try and conceive?
Oh, yeah, that's like opening a can of worms there. Embolization is, I guess some people maybe also be aware of the new method of managing fibroid, which is called HIFU, high intensity focused ultrasound. What all this do is a bit of a different way of managing fibroid. The embolization destroys the fibroid cell, so it dies, but it doesn't remove it. So it shrinks over time. The critical mass is about how much shrinkage you get and where is the location. Embolization in carefully selected cases will reduce period and also reduce pressure symptoms. But if a woman has submucosal fibroids, then it becomes a bit of a problem, okay, in the sense that there's persistent vaginal discharge, and then there's irregular bleeding until the fibroid is passed out, okay? And if it's an intramural fibroid, that's about 6 centimeter, it could shrink it down to less than 5 centimeter, in which is okay. But generally speaking, if a woman has not had a baby, I don't tend to encourage embolization because the risk is minimal, 1% risk of ovarian failure. But in a woman who is trying for fertility, then it becomes 100% if it happens to the patient. I've seen patients who have had primary ovarian failure as a result of embolization. So I don't use it as a primary line of care for somebody who hasn't had children, just because of that little risk. Of course, the fibroid, if it is accessible to surgery, will still be better done to open this surgery. It's about location with embolization, and also age.
Absolutely. Well, that's very useful. Thank you for clarifying that. So we have come to the end now of the webinar. So I just wanted to say a big thank you to our wonderful speaker, Mr. Abiodun Fakokunde, for being with us tonight. And thank you all for bearing with us for the delay. And we got there and we had a fantastic presentation. So thank you to you all for joining us. Please don't forget that we are your charity and we are here for you. So if you need support, we have groups across the country and UK-wide groups which you can join. You can contact me, the FNUK Ethnic Minorities Communities Project Worker, and we also have a support line and information line that is open, so please do not hesitate to get in touch. And Mr. Fakokunde, we will be delighted for you to come back. As you mentioned earlier, your colleague will be doing a webinar with us around fertility testing, but we'd be delighted to have you join us again. So thank you so much and wish you well. Take care.
Thank you so much for inviting me. It's been a good evening. Thank you.
Thank you.
I'll get savvier with my networking later.
We've had some great feedback here just to share with you that we've had the last feedback. Thoroughly enjoyed that lecture and Q&A. Thank you to all who organised and of course to Mr. Fakokunde.
Thank you very much.
Thank you.
Thank you for the opportunity. It's been a big pleasure. Okay.
Take care, Paul. Thank you.
Yes. Bye-bye. Thanks, Jenny.
Thank you. I'm just